I'll now move on and introduce our first keynote speaker, who I think probably is well known to everybody in this room. Professor Sir Stephen Powis took us through the pandemic and was knighted for that very reason, for services to the NHS, emphasising his role during the pandemic. He was trained as a nephrologist, and I was just reminding him that we sat in the same SR club many, many years ago, because I was a renal physician, but that's a very, very long time ago. But it's also fair to say that Steve has moved through his career, becoming the MD and CMO at Royal Free. He was the Moorhead Chair of Renal Medicine at UCL and has been the Medical Director for NHS England since 2018. As many will be aware, he announced his retirement before everything else was happening for July. And so on that note, if I can hand over to you, Steve, thank you very much for coming to talk to us.
Well, good afternoon, everybody, and thank you, Mike, for that kind introduction. And yes, I did announce that I was stepping down in the summer after 7.5 years before the other changes that have been announced. This summer actually also marks, and you can tell by Mike referencing our SR clubs together, it marks the 40th year since I qualified as a doctor in 1985. So I hope you'll forgive me if I am in rather reflective, perhaps even nostalgic mood as I think about postgraduate medical training. I'm not going to deliver you a keynote because I've only got 6 minutes left. So this will rather be a few comments that hopefully will set the scene for a discussion that we can have in a few minutes. But in being in that reflective mode, when I think back to my time as a young doctor, I think many things have changed over the course of that 40 years. And of course, postgraduate medical training is one of those things that has absolutely changed a lot. When I was going through training, well, it wasn't really training. It wasn't structured at all. And it was perfectly possible, I would say, for some to wander through different jobs without any particular purpose, particular support, or particular advice in terms of what a career structure or what a career progression might look like. Now, that's not to say that there weren't great teachers, there weren't great trainers, and there wasn't a great training experience. But one of the things that has absolutely changed over the last 40 years is that the structured support that we give to those in postgraduate medical training has increased many-fold, and it's in an infinitely better place than it was back in those days. And our doctors in training benefit from that, as do our patients and the public. And I think we should be really proud of that, because it's everybody in this room and colleagues who over many years have delivered that. And of course, that system relies on many people: educational supervisors, clinical supervisors, training program directors, and many more, all the things that we didn't have back in my day. Much better curricula. So when I first joined the renal SAC many years ago, I think the curricula was 3 pages long. By the time I'd finished as chair, a number of years later, it was probably 100 pages long. Now, you could argue whether that's a good thing or a bad thing, but it certainly was more comprehensive, it was more detailed, and it gave much more information to our trainees as to what the expectations were in terms of knowledge base to progress through their career. We've heard about training surveys. Wonderful tools to take the temperature of how trainees are feeling and trainers, but also showing where improvements need to be made. And of course, we have many standards, standard documents, quality standards, but others. And of course, the standards are being launched today. The IMT quality standards are a really good example of that. And I thank the Federation and commend them in the work that you've done in producing those. So training today is much more structured than it was when I started, and I think overwhelming that is a positive thing. But there is a question. There is a question as to whether it's become too structured. And one of the things that I often hear when I talk to resident doctors, doctors in training, is a desire for more flexibility. And that's one of the reasons, it's not the only reason, but it's one of the reasons that the Chief Medical Officer in England, Chris Whitty, and myself have launched the first stage of a review of postgraduate medical training. That exam question is, have we got that balance right between structure and flexibility? And if not, how do we achieve that without losing all the advances that we have made? It's not the only reason to have a review. Many things have changed in the couple of decades since we last had a good look at postgraduate medical training. To name but a few, the service is much more consultant delivered than it was. Huge amount of benefits in having senior decision makers making decisions, but that can disempower resident doctors and doctors in training from making decisions if we're not careful, and sometimes from gaining, particularly in the craft specialties, the numbers of cases that they need to have undertaken in order to progress through their careers. The teams that resident doctors work in and doctors in training are so much bigger than they used to be. When I started as a consultant, as Professor of Renal Medicine at Royal Free, I was the 4th consultant. By the time I left, 18 years later, there were 25 of us. Those teams are also much more multi-professional. And that is, again, something that's really positive. It's delivering benefit to patients. We're not going to go backwards. But it does mean that it's harder, particularly for people who are rotating frequently, to become embedded in teams in the way that maybe I did when I was working with 2 or 3 consultants over the course of a 6-month rotation. Thirdly, demographics of the population are changing. You all know that. The population is aging. That's a good thing. Life expectancy has been increasing, but predominantly we are now managing, both in secondary care and actually in primary care, a population of people, and I'll soon be there, in their 70s, 80s and 90s with multiple conditions. And so that leads us to a place where we need to get that balance between generalism and specialism right. And if the Chief Medical Officer here, we point that many of those people are not living in urban areas such as London. They're living in rural areas and coastal areas, exactly where we don't have the concentration of health resources, which are predominantly still city-based. So we need to think about how we respond to that. And then finally, in England, and I'm conscious this is a UK discussion, but in England, we have a new government with a new 10-year plan that is about to be launched later this spring. And that is a good opportunity to link into in terms of thinking about postgraduate medical training. So why have Chris and I chosen to lead this? Well, it's something I think I've thought of for a number of years that we need to get round to doing. And the opportunity has arisen, new government, but a number of other things as well. But Chris and I want to lead it because we firmly believe that this, first and foremost, needs to be a professional discussion and a professional conversation. And part of that is because we think that many of the solutions to the challenges that we are facing can come from within the profession. And in fact, if you read the standards document, I'm struck by how many of these actually are things that the profession can have control over. Now, that's not to say that government, that NHS England, that other bodies, colleges don't have control over some of these things, but I think sometimes we underestimate just the power of the profession in making the changes that we want. So it needs to be a discussion with the profession, and we need to work with the profession to bring the solutions from the profession. Now, there are 3 things that we usually always say when we're talking to resident doctors, but also to wider groups. So the first is that we are where we are today because of a set of really important and well-meaning decisions that were made by the clinicians that went before us, predominantly the clinicians that went before us, who were responding to a set of issues 20, 30 years ago. And they were done in good faith, and to a large extent, they addressed the problems of the time. And I've talked about educational structures being much stronger as a result. But things have moved on. No doubt in 20 years, somebody else will be on this stage talking about the people who made the changes 20 years previously. Medicine evolves, society evolves, we need to change with it. But that doesn't mean that the changes that were made previously were poor or not well-intentioned or have had meaningful impact. Secondly, there's always a set of trade-offs. There's always a set of tensions that can never completely be resolved. Service versus training is one of the classic ones. There's a set of balances that need to be struck. One person's flexibility can be another person's constraints. You can never get a system design that will be perfect for everybody, and we need to understand that those trade-offs are there. We need to understand what they are, and we need to work our way through ensuring that they are well balanced. And then thirdly, changing postgraduate medical training can be tricky. And we all know, those of us that have lived through MMC, MTAS, know that it doesn't always go as well as planned, and that's because it's really complicated. And you move one part of it and another part of it is affected. So this needs to be done carefully, it needs to be done with thought, and if we are going to change things radically, and we may not have to do that, then we need to think through it quite carefully as a profession, but also as a wider group of interested parties. So how are we going to do this? We're going to do it in two parts. We have made it very clear that we don't want this to be a top-down set of suggestions and propositions. We want this to be a bottom-up process where we hear predominantly from resident doctors, but not just from resident doctors, because they are not the only stakeholders. The colleges are stakeholders, patients are stakeholders, employers are stakeholders, and many others. But we want to hear potential solutions. We want to understand what the main challenges are and main issues are. And then, as it stands at the moment, we aim to get that work done by July, and then I anticipate there will be a second part that will be a set of next steps based on what we hear, what we conclude from that first part. Of course, Chris and I are not doing all the legwork, Jeff is. So Jeff and colleagues, Shona and the team at the Workforce Training Education Directorate in NHS England are really supporting us in this, and I'm really grateful, Jeff and colleagues, and Jeanette at the back, and the Academy and the colleges are also really supportive and are sitting on the steering group. So we will be doing this collectively. And I'm very conscious also that this is an England process. We have discussed this with colleagues in the devolved administrations. They are aware it's going on, watching it carefully. But this particular part of the process, this first part, is very definitely England only. So for everybody in the room, do take the opportunity to get involved. We are holding a number of events. Some of you have been at some of those already. We will be launching a call for written evidence. We're doing an international review. We are looking at what the evidence is around the world. And I hope if we get it right, then we will have something to say in the summer. And I think I will stop there. Thank you, Mike.
I think one of the most important things is valuing educators. And clearly we're in a process of flux and change at the moment. And my concern about the process, and it links in with the quality process, but links in with reform, is that we don't recognise both the time required and the finances required for education. Because if we want to deliver good curricula and good quality standards, we need to have educators there. And the balance that is seen in the workplace now of an inability to be an educational supervisor, the lack of people coming forward to be TPDs, is of great concern. I'd be interested to see what your thoughts on how we move forward.
I absolutely agree with you that this is also around ensuring that we have now that we have those structured training programs, the people that support them are well supported, and you saw, Mike put it up, didn't you, a drop in the percentage of trainees who feel that they're supported by their educational supervisor, not by their clinical supervisor. So I'm very aware of the stresses and strains on supervisors. Why is that happening? Well, post-pandemic, one of the reasons it's happening is that we are all working on elective recovery, we're working on a challenged UEC system, and I say many times, including to political colleagues, it's generally the same group of people who are doing all of that. There is not generally a separate set of people who are just doing educational supervision, nor should there be. So we are stretched in many, many different directions. So it is something that we will need to solve. I'm sure it is something that we will hear as part of the review, and it's something that I think we will need to probably say something about. And I think the other thing that I'd say is I think one of the things I'd like people to think about is whether we extend that educational supervision beyond those people who are in training posts. Because we have a lot of doctors who are not in training posts, and one of the things that we're seeing is an expansion of locally employed doctors. Now, I know full well, because I did it when I was at the Royal Free, that doctors who are not in training posts are not by and large excluded completely from training opportunities. If you're giving a seminar on, membranous nephropathy, you ask all your resident doctors along. But nevertheless, those in training posts get more structured supervision than those aren't. If that's to be done, not saying it has to be done, but if that's something we need to think about, then clearly we will need to think about how we support our educational and clinical supervisors, because we will potentially be asking them to do more. And of course, there's all sorts of things in terms of innovation, technologies that we need to use as an adjunct. It's not just around the people, but fundamentally I agree with you.
It's also the administrators.
And yes, and it's the teams, yeah. So it's not just the supervisors, it's the teams of sport.
Thank you very much, Sir Stephen. That's been really, really helpful and very insightful.